two, one. Please start, sir. We are live.
Yeah, fine, fine. Just I'm giving the introduction. So, good evening, speakers and everyone joining us today. It's a genuine privilege and honor to welcome you all to the Bayer Eyesight virtual meeting. Today, we are conducting this meeting on DME, and our first topic is diabetic macular edema from understanding to treatment. And the speaker is Dr. Abhijit Pal sir. Sir is associated with Disha Eye Hospital. He is a very young, promising medical retina specialist in Disha Eye Hospital. And our second topic is visual outcome in DME, assessing the efficacy of Q16 aflibercept injection. And the speaker is Dr. Kunub Das sir. Sir associated with Roshni Eye Foundation, with CFS and with other organizations. So this the small briefing of our topic and our speakers. So now I want to hand over the session to our first speaker, Dr. Abhijit Pal sir. Thank you.
Thank you. Am I audible?
Yes, sir, you are audible, sir.
Yeah, thanks the team for inviting me and giving me the opportunity to present. Yeah.
Just click on the slides and go back to the first slide, sir.
Okay. Is it visible?
No, sir.
No, sir, slide is not visible, sir.
Slide is not visible, and then I have to share it again. One minute, please. So Zoom, I have opened already. Now it's visible.
Yes, sir. Just go back to the first slide.
Yeah. Okay. Yeah, visible.
Yes, sir.
Okay. So, sorry for the delay, some technical glitch. Today's topic of mine is diabetic macular edema from understanding to treatment. So, before starting, I
Sir,
want to highlight.
sir,
Yes.
sir, interrupting you, sorry. Please
Uh,
open your video, sir.
oh, sorry.
Okay.
Sorry.
No, no,
Yeah,
it's okay, sir.
I'm just searching that video. It's not coming. Why? The slide is been changing. Is it coming now?
No, sir.
Now.
Just click on the slides and
Yeah.
use.
Yes. Okay.
Yes,
Yeah,
sir.
it's fine, fine, sir. Now it's fine.
Before going to my topic, I want to highlight that now in the era of AI, artificial intelligence, and all the retinal diseases and the improvement of the drugs day by day going on. So there, from the history point of view, we are coming across several molecules, but still our journey is going on. So there are needs of more improvement, we all know. So the thing is that like retinal diseases like diabetes, and also not included in the topic today, like weight ARMD, PCV. There are lots of entities that there's the retinal disease are going on, and we are trying our best to treat the patient to gain the vision in long term. So why we are focusing on these? Like our long-term benefit is very important. Initial molecules been practiced everywhere. They can give the initial good outcome, but the long-term benefits, safety and efficacy are issues. So from that point of view, it's very interesting today. We will discuss from understanding to the treatment. So my first, yeah, there are usual disclaimers. This is the slide for it. And first we have to understand the burden of diabetes. If you see the different zones of world, it's increasing, and you will be shocked to see the percentage. Southeast Asia, it's 74%, even though it's increasing in everywhere. Now also in Africa. So it's where the it's like the peoples or the countries belong in poor socioeconomic group, they're suffering more. And because the availability of treatment options are less. And if you see the percentage in Southeast Asia in 2045, it will increase like 74%. So it's really a matter to be concerned. So I am just going to directly my topic in nutshell. So we are all concerned with diabetic macular edema. Why? Why it's so? Because of diabetes, there are vascular occlusion and vascular damage that leads to release of mediators, which subsequently causes vascular leakage, fluid collection, and gradually, if not treated properly, there will be drastic complications like formation of new vasculature. So, as the pathology goes on, there are accumulation of fluid in the macula, and that disturbs the retinal RP cells. So, the visions gradually goes down. So, actually, the what is the key factors who plays role in the pathology? Actually, there are several mediators. Most importantly, it is vascular endothelial growth factor A. Even though it's very important, there are other factors like placental growth factor, and we'll subsequently discuss all the points. So now the DME is the leading cause of moderate to severe vision loss in the patients with diabetes, and the leading cause of blindness in the working age group people in developed countries. And it present both in type 1, type 2 diabetes. And if we see that vision loss in the patients with DME can have life-changing consequences, we all know there will be difficulties in near visions and other activities, driving, reading, all the quality works compromised because of visual the decrease of quality of vision. So in the picture, the right-hand picture, you can see the regular picture like that color photo showing hemorrhage, hard exudates, and clinically significant macular edema. And in the left side, we can see that there is accumulation of fluids which causes vision problem and subsequent RP damages. So actually, what I initially started with that to treat diabetic macular edema from the era from the past, we are seeing several treatment options are going on like laser, anti-VEGFs. Later it came. So the landmark studies, ETDs started regarding laser photocoagulation as the needs are not met by laser photocoagulation alone. Then anti-VEGF steroids are coming, and since 2021, the newer molecules like ranibizumab ranibizumab was been used, and then it's been shifted to newer molecules like aflibercept, faricimab, and it's not been written brolucizumab. And also dexamethasone in 2014. So there are several, what I mentioned earlier, that studies are going on. We are searching the best molecule to get to relieve patients in long term. So, what factors are the key to cause that all the problem? So, if we see this slide, they're mentioning of that mediators like vascular endothelial growth factor A. There are also one entities B and placental growth factor, and there is heteromer of VEGF-A and placental growth factor. Actually, if you see they act through the receptors. Yes, the vascular endothelial growth factor A acts via receptor 1, VEGF receptor 1 and VEGF receptor 2, and placental growth factor acts directly via VEGF receptor 1, and then it indirectly activates receptor via receptor indirectly activates VEGF receptor 2, and the heterodimer activates both VEGF receptor 1 and 2. So excessive activation of VEGF receptor 1 and 2 results increased vascular leakage, edema, inflammation, and pathological neovascularization. So what I said, I mentioned diabetes is a vascular disease. Because of uncontrolled sugar, there is vascular damage, which leads to hypoxia. That leads to release of VEGF and placental growth factor. Subsequently, that activates receptors, and all the pathological cascades goes on, like endothelial cell apoptosis and pericyte drop and opening of tight junctions that leads to breakdown of blood retinal barrier, leads to hemorrhage and microaneurysms and vascular leakage and edema. And again, that mediators causes more inflammation, more cytokine release, more binding to the VEGF receptor molecules, and again inflammatory cascades goes on, which leads to chronic inflammation and RPE change. As it goes on, the inflammatory mediators causes neovascularization also. So these are the basic pathology. So till date, what we had done, that we try to find out to control or to treat the molecules. So we know ranibizumab acts on VEGF-A, and Brolu also, even though it's a low molecular, the benefits is that low molecular weight. Again, it acts on only VEGF-A. But if only VEGF-A has been blocked, it is not the job done completely, because VEGF-B, placental growth factors, these other mediators come in action and does all the pathological processes. So aflibercept is one which is tackling all these three. There are other mediators also, but the crucial mediators are these. The aflibercepts are acting on VEGF-A, VEGF-B, and placental growth factor, which are promising to control all the pathological events caused by the mediators. So in summary, we can say, like we can sum up like VEGF-A, VEGF-B, and placental growth factors are three key driver behind the pathological process of DME. So, and aflibercept is the only global available anti-VEGF that can target all these mediators. So now, how we can decide which molecule we use. Just we have discussed how the mechanism action is going on. Then we can see or focus the RCT trials, real world evidence, and network meta-analysis, our own experience. We are using anti-VEGF for long. We started with bevacizumab, then shifted to ranibizumab, and then also apli, and we are using all. So we are getting, we are comparing the efficacies, safeties. So from our own experience, we are choosing our anti-VEGF of choice. So we can just now I will discuss in nutshell, because it's a huge topic, discussing all the landmark studies. Just key points I'll discuss, that Vividan Vista, what it shows what it shows regarding aflibercept in DME. So in this business slide, we just focus on the slide that the gray line is showing the laser arm, and that yellow are showing 4 weekly 2 milligram aflibercept, and the blue is showing 8 milligram aflibercept. The left side showing Vivid study, and the right is Vista. The mean number of injections required in year one, it's in 2 months group, 8 weeks group is 8.7, and 4 weeks group is 12.2, and it's also the similar in Vista. And we can see that visual gain is much more higher than laser group. And even you can see that 4 weeks groups shows little bit better in Vista study. So what in we all know that protocol T, what the result has been shown first year, which has been the study has been done with the laser, ranibizumab, and aflibercept. So in sum up, what has been shown that visual gain or observed early as with the first aflibercept injection, and patient received more than 8 injection through year one and maintained visual gain during the initial loading phase. And across all the studies, patient treated with aflibercept gain on average more than 10 letters. And at the week 52 weeks, the aflibercept demonstrates superiority to laser in this Vivid and Vista study. So again, it is a busy slide. I am not go through in detail. This slide is showing that the laser group, after a certain period, after week 100, they are allowed to receive aflibercept on PRN basis. So when these patients are being studied at 148 weeks, overall message from overall take on from that if we delay to start proper anti-VEGF, then the visual outcome will not that great as which has been seen in the group who receives aflibercept early. So meta-analysis, what it shows regarding aflibercept, here, it's a Cochrane meta-analysis reviewed evidence from major studies investigating the efficacy of anti-VEGF in DME. The key conclusions is that at year one, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab, and patients are approximately 30% more likely to gain more than 3 lines with aflibercept than ranibizumab and bevacizumab at year one. And here we don't get so much of serious systemic adverse events at year 1 or 2. And other meta-analysis also shows that aflibercept 2 milligram 8 weekly shows superiority to ranibizumab 0.5 milligram PRN for mean change in the BCVA gain of more than 15 ETDRS later, and loss more than 10 ETDRS letters from the baseline in month 12. And if you see that right handed chart, that it includes aflibercept, ranibizumab, and laser arm, and ranibizumab only. So it shows the mean change at month 12. We're getting more gain in aflibercept group. And also the reduction of the central macular thickness also more in aflibercept group than ranibizumab laser arm or ranibizumab alone. So again, aflibercept is the most favorable treatment in terms of BCVA improvement and CMT reduction compared with other therapies in 12 months period. Actually, why it's been showing superior, like that if we rethink that why we have just go through like aflibercept, what it does, how what is the mechanism of action. Like it's acting on the mediators like VGF-A, VGF-B, and placental growth factor. So the other molecules like they're focusing on only VGF-A. So if the VGF is only been down-regulated, the other molecules are acting and they are causing all the pathological events. So as the aflibercept are tackling all the mediators, it can give us more good result, which is efficacious and which is in long run, the visual gain has been maintained. So this slide is showing again, it's I think international guideline and recommendation that suggest that aflibercept is the drug of choice in patient with VCVA less than 69 letters. That is the Snellen score is 20/40 or worse. So there are several guidelines like EURetina, Asian recommendations, Diabetic Canada guidelines, German Ophthalmological Society guidelines. So if we see their keynotes that the EURetina is saying that aflibercept is a drug of choice in DME eyes with the baseline BCVA below 69 letters, as it shows superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. The same thing has been repeated in all the GLADs. I am not going through it. We can see that in the year 1, it's showing superiority in terms of visual gain, in terms of safety. So can these guidelines and meta-analysis form the anti-VEGF treatment of choice in our clinical practice? Yes. You can see it's also a busy slide. If we see the slides, we can see the visual gains here. Again, it's also showing that aflibercept it's more superior than others. Okay, and see the right handed bars where we can see the ranibizumab 0.5 milligram and the aflibercept. We can see that mean visual change among the patients more than 68 letters at baseline. We are seeing that the injections, I think, yes, higher proportion of the patients switch from ranibizumab to aflibercept shows better result. Okay, so the adjusted mean visual gain from baseline to month 12 in eyes with initial vision of less than 68 letters was significantly higher in the eyes receiving aflibercept than those receiving ranibizumab with a similar number of injections. So I am not going in detail to the visitors. All the sites are showing the superiority of aflibercept. Okay. Okay, so in sum up, what we're getting from all the landmark studies that aflibercept can achieve meaningful visual gain in patients with DME as demonstrated by RCTs, meta-analysis and international guidelines and the recommendations suggest aflibercept should be the drug of choice when we are treating or dealing with the patient with baseline visual acuity less than 69 letters. And patient with visual impairment due to DME, particularly those with, again, the same repetitions, the visual acuity less than 20/40, we can think of aflibercept. Thank you.
Thank you, sir, for a wonderful presentation. How we elaborately discuss the every point or every slide of the presentation. It is really helpful for our audience. Like from the superiority of the molecule, the structure, the beauty of the structure of this molecule, the blocking of all PIGA, VGFA, how we discuss that this point is really helpful for our audience. And after that, it's backed by the guidelines like EURetina guideline and others German guideline that also supported that this is the best molecule. After that, we have in this PPT we have the study like Moorfield study that is real world study. So there is also matching what we are claiming with the vivid vista style. So you can see the all parameter. It is given that this is the base. It should be the base choice. It is the base molecule for your patient DME and AMD. But sir, what your experience with this molecule? Because you are using a molecule for a few, good time. So what your practical experience? Just because this gives a confidence to the audience. That's why I'm asking.
Yeah. The clinical, what
Clinical.
actually, yeah. So actually, truly speaking, the economy, what we have, like the peoples are coming to us. Most of the time, if we offer them, even though we have already just get from the studies, like if the visions are less than 20/40, we should offer them aflibercept. So sometimes we can't able to offer, even though we explain. Like we offered them that aflibercept will work better. So some patients, some no, majority of the patients can't afford. So we have to start with the basic molecules like ranibizumab. So what we have seen that like the effects are not lasting for more than 1 month. Sometimes it's 4 to 6 weeks, but even immediately after that I am seeing that it's only not in DME, it's on other retinal diseases also. The pathologies are coming back. So sometimes patients are reluctant to receive the next therapies. Sometimes they are receiving. We are giving injections almost 4 weeks, 6 weeks duration. So the requirement of injections are much more, and sometimes we will lose our patient. But meanwhile, when we are getting the recalcitrant patients like recalcitrant macular edemas, treated elsewhere, the same scenarios, received the basic molecules. So I have significant number of that patients like that. So I tried next time I will share all the slides of those patients. So they are amazing in the sense like as we just discussed, no, like that mediators, the control, actually all the pathology goes on because of the mediators, uncontrolled mediators. We have discussed major three. There are other mediators also, you all know, and Ang2 also, no. So these play a very important role. One important thing I want to say you that Ang2, we are really now what I say, now it's a very important mediator, because someone is proposing that inhibiting Ang2 is really good, something magic. If we read that, if we go through actually the what is happening with Ang2, the message is that if we able to control VEGF properly, Ang2 down regulation will be automatically happen. So this is also an important thing. So if we focus on these molecules, the other molecules, other pathological markers also been down regulated. So Afli is really very good. I am eagerly waiting for the new molecules to tackle more difficult situations.
Thank you, sir, for showing your confidence with the real time using of the aflibercept. Yeah, hopefully we are coming with the our new strain. Hopefully in next VRSI we are going to launch our 8 milligram strain. So thanks for your confidence. So now I want to hand over the session our next speaker, Dr. Pranab sir. Thank you.
Thank you.
Good evening, everybody.
Good evening, sir.
Good evening. Very nice presentation of Dr. Vijit.
Thanks, Sada.
So it will be a little bit of repetition of the same presentation. I think there are a few common slides also. Is my slide visible?
Yes, sir, it is visible, but not in the slide mode. slideshow, not in slideshow mode, sir.
Now it's
Yeah. Now it's perfect, sir. Now.
okay. So my topic is visual outcome in DME, assessing the efficacy of Q16 aflibercept injections. So Dr. Abhijit has nicely shown the effect of aflibercept, efficacy of aflibercept in treating the DME. Here I am going to show you the extended dosing of aflibercept in tackling the diabetic macular edema. So as we know, the burden of diabetes mellitus is increasing worldwide, and more so in our part of the world, that is Southeast Asia. In 2019, there was approximately 88 million diabetic population in Southeast Asia. It is expected to increase by 74% by the end of 2024, that will reach 153 million. So you can imagine how much will be the burden. And the proportion of the patients with diabetes who have sight-threatening DR is expected to increase alongside the rising diabetic population. It is estimated that there are approximately 28.54 million population having the DME by the end of 2020, and it is expected to rise to 44.82 million by 2024. So, and one important aspect is that diabetic eye disease is the leading cause of vision loss among the working age adults, unlike the ARMD. Vision loss is the most feared complication of the patient with diabetes. This was the questionnaire given to the newly diagnosed diabetes mellitus patients. 50% of the actually feared of losing the vision, and the rest are far way lower than the vision loss. It's like cardiac, the thought of cardiac problem in 21% patients, and renal problem will face thought by the 11% like that. So almost 50% of the patient are actually apprehensive of losing vision as soon as they was diagnosed with the diabetes mellitus. So effective treatment options provide the opportunity to improve the independence, productivity, and ability to perform daily functions. So here we are showing that how every line of gaining vision can improve the quality of life. So gaining one line may help patients read a newspaper and drive at night or under difficult conditions. And gaining two lines may improve ability to perform near vision tasks such as cooking or using tools, or increase patients' ability to work and perform a role-specific function. Gaining three lines may help improve the color perception. And if you can retain the vision about 2040, that may help patients to retain their driver's license, reduce the risk of mental illness compared to the vision less than 70 DDRS later. And that there is a potential for the dramatic impact on patients' daily lives if you can maintain the visions at more than 2040. So this has been already shown by Dr. Abhijit, which actually says that at the end of 3 years, the patient's the visual acuity gain is almost 10 to 11 letters in both in PVT and VISTA at the end of 3 years, and DRCN.NET protocol also the visual acuity gain was 12.3 to 12.8 letters in aflibercept group. The patients from VISTA maintained visual acuity gain for 5 years with a mean of 3.4 injection in the year 5. So the initial years, the number of injections required is high, but at the end of 5 years, even though we can maintain the vision at the whatever we improved by the end of say 1 or 2 years, with the minimum amount of injections, that is 3.4 injection in year 5. So patients were observed at 4, 8, 12 weeks interval, depending on the disease stability, substantial reduction of the treatment burden through the 2 years. That is 25% of the patient required no retreatment, and 48% of the patient received 5 or fewer injections. So that is what the endurance. So there are international recommendation guidelines that recommended the first time use of aflibercept in patients with the vestibular visual acuity less than 69 letters. That is 2040. So it has been shown by the protocol T also. When the initial presenting vision is low, the Eylea works better than other anti-VEGF molecule. So patient presenting with visual acuity of less than 69 letters are in commonplace in real world settings. Then aflibercept, the drug of choice in DME patients, visual acuity below 69 letters, as it shows superiority to the bevacizumab over 2 years and over ranibizumab in the first year of treatment. So, and in patients with the poor visual less corrected visual acuity, that is worse than 612, aflibercept may lead to a more rapid visual acuity improvement than the ranibizumab over 1 year, although difference was not statistically different by the year 2 of DRCS.NET protocol T study. And superiority of the aflibercept was noted in the group of participants with worse baseline visual acuity. These superiority of aflibercept at year 2 with the gains of 18.1 letters in aflibercept, 13.3 letters in the bevacizumab, and 16.1 letters in the ranibizumab. So you can see that ranibizumab and aflibercept almost comparable when the visual acuity at the presentation was worse and far better than the bevacizumab. There is evidence for a possible difference in drug efficacy in patients with DME to the advantage of the bevacizumab at a visual acuity of less than 20/50. So aflibercept is recognized as the standard of care in DME and is being used in 4 DRCA network, retina network protocols evaluating the anti-VEGFs in DME and DR, like Protocol W, Protocol AB, Protocol P, Protocol T, and Protocol AC. I will not go into the details of these. Then we'll come to the Violet study, which evaluated the long-term benefits of the aflibercept in patients with DME with different regimes after early intensive treatment in year 1 in patients from the AQUA. So in the Violet study, basically all the patients were actually enrolled for the AQUA, then that patient been shifted to the Violet study. So basically, it is a multicentric open level randomized phase 3B study to evaluate the efficacy, safety, and tolerability of 3 different treatment regimes of aflibercept 2 mg in patients with DME previously enrolled in the AQUA study. The patients were randomized 1:1:1. The aflibercept in one arm, aflibercept Q8 weekly were given 2 mg Q8 weekly given at fixed dose basis, and aflibercept in the second arm, the patients were enrolled for the treat and extend regime in the year 2, and in the third arm, the aflibercept was used as the PRN basis. So primary endpoint were the mean change in the visual acuity from the baseline to the week 52. That is the second year, and second week 52 primary endpoint was the continued treatment through the week 100. And secondary endpoints is the change of best corrected visual acuity from the baseline to week 100, change in CRT from baseline to week 52. So what we can see here, these results from the 2 mg Q8 extended regimes groups confirm that this posology has a similar efficacy to fixed and PRN treatment regimens, where while markedly reducing the number of office visits compared with the PRN treatment regime in the Violet. So what we found here that the treat and extend regime gave benefits of lesser office visit or lesser clinic visit. So that is what is important. And you can see the results are almost similar. And you can see here patients would gain more than 10 letters at week 100, that is at the end of 2 years, was in the fixed dosing to 6.5, in treat and extend was 11.2, and in PRN it was 14.4. So this is the BIVIM study which evaluated the outcome of year 2 proactive treat and extend regimen with the aflibercept for patients with DME. Again, a prospective multicenter single arm study assessing the efficacy of treat and extend regimen with the aflibercept in patients with DME over 104 against 2 years. So all the patients were assigned to the treat and extend regime after 5 loading dose. So here the primary endpoint was best corrected visual acuity from baseline to week 104, and secondary endpoint is the best BCVA from the baseline to week 52. So mean treatment interval is 4 weeks, and the maximum treatment interval is 14 weeks, when it's extended by 2 weeks interval. So what do we see? The mean change in best corrected visual acuity from the baseline at the end of 1 year, it was 9.1 letter, and in the second year also the same, almost same visual gain was maintained, and approximately 35% of the patients gained more than 15 letters at the end of. So one third of the patient gained more than 15 letters of vision at the end of 2 years, and you can see here the other thing, 57% of the patients were on more than Q12 treatment interval at the end of year 2. So more than half of the patient can be kept on 3 monthly dosing. And mean number of injections in the first year, it was 8.5. The second year, it drastically came down to 3.9. So in the Hirano, it also says the proactive individualized treat and extend therapy with the aflibercept patient with the DME over 2 years. Here, aflibercept 2 milligram Q4 for 4 months followed by the individual treatment. Again, the same kind of study. Here also the mean change in visual acuity from the baseline to 1 year was 6.180 DRS later. Mean number of injections from the baseline to year 2 was 11.14. So this is the 2 years total. 11.4, almost similar. In the earlier study, it was 8 injections in the first year and then 4 injections in the second year. So it is almost 12. Patients completing the 2-year follow-up were 75%. So what is important is the 66.7%, is 2/3 of the patients were more than Q16 treatment intervals at the end of year 2. So 2/3 of the patient could be actually given injection at 4 monthly interval. So that is what the encouraging thing here. And this is another study. I'll not go into the details of this. In prospective clinical trial, majority of the patients with DME achieved more than Q12 treatment intervals after 2 years of proactive treat and extend. So what we can see, more than half to 2/3 of the patients actually can be kept under more than 12 weekly regime if you are using the aflibercept, and especially if you are going for the treat and extend regimes. So this is again the same thing. So in summary, aflibercept can achieve the clinically meaningful visual gains or maintain the vision regardless of baseline vision, and is the treatment of choice, particularly in the patient with baseline visual acuity less than 69 letters. Early extensive treatment followed by a treat and extend regime in DME can also maintain vision with reduced burden to patients in clinic. Patient factor beyond the baseline vision, such as duration control of diabetes, can also have an impact on risk of vision loss in patients with DME. Overall, early treatment of DME with a good systemic control diabetes, regular follow-up in patient can maintain the vision for long period of time. And aflibercept is the only bispecific VEGF fusion protein that is designated to trap the VEGF and the PIGF. This is very nicely and elaborately said by Abhijit in this presentation. So early intensive treatment of DME may maximize the vision gains in the first year, and these can be maintained in the long term with a reduced treatment burden. With proactive individualized dosing, patients can maintain visual acuity gains with a reduced treatment burden after year 1 with aflibercept. Then emerging real-world studies in DME have shown that aflibercept leads to good visual and anatomic outcome in the clinical practice that are consistent with those reported in the clinical trials. Thank you very much.
Thank you, sir. Thank you for a very insightful presentation. It's really enriched our audience and help their day-to-day practice, and they will get the confidence that they can treat with the extend the durability with aflibercept, because the main maximum of the ACB complaint that the patient don't want to take so frequently injection. So obviously with the use of aflibercept, they can extend the durability. So now the forum is open for the audience if there is any question, and I also request Dr. Ovi sir, if you want to any point from your side, you can ask Sukumar sir. Thank you.
May I?
Yes, sir. Yes, sir.
Yeah.
Always.
A nice presentation, Prananda.
Thank you, Abhijit. Thank you.
Yeah. We all know all the studies are promoting treat and extend, but is it possible
Yes.
in Indian scenario like West Bengal to offer the patient in treat and extend model? Because I
Mm,
can't able to maintain these, even though repeated counseling and showing, even I shared study data, not in detail, that landmark studies অনেক কিছু স্টাডি হচ্ছে এইসব নিয়ে I explain them in their language. Still, I can't able to manage to stick to treat and extend rather PRN. So, what is your take on that? How you manage your patient?
no, you are absolutely right. Uh, I think majority, almost, I mean, I think 90, more than 95% we follow the PRN visit. Our patient not going to take injection when even when there is no fluid. Okay, treat and extend means suppose you have given injection at 8 weeks, then next time, irrespective of the fluid, it is say 10 weeks. Hmm. So our patient is most of the patient will not take that, accept that regime. So we, like you, I also follow the PRN basis. And another thing is that not that PRN we are giving more injection. Only thing the patient has to come little more for the visit. I think that is the only thing. In injection number of injection, I don't think treat and extend will require less number than the PRN basis. With my personal experience.
From the one thing is that I just experienced, like we all focus on treatment parts, like ocular treatment parts like injections and say.
Yes.
I
Yes.
found that that systemic control, we all know that. We all know that the
Absolutely.
systemic
Absolutely.
control is the main part. I am truly telling you that some patients comes to me with they show the report like my sugar is controlled, my HbA1c also under 7, but still it is going on. So I found that as it is multifactorial, like patient has pressure, their pressure fluctuation, their lipid dyslipidemia. Some patient,
Exactly.
female patients especially, if there's an associated renal problem, they have
Mm.
low hemoglobin. So these are all the multifactorial things we have to think of. Even though you offer all the good molecules, if the systemic parameters are not being controlled, no, sometimes it is difficult. And I have patients like I have tried all the very good molecules available in the market. Still, it's not been controlled with that. And sometimes there'll be there are refractory edemas and refractory cases. So when I deeply go through the cases and studied, so I have seen there's some amount of other abnormalities are playing a role. So it is also very important to look for that also.
Absolutely. We should treat the patient, not the eye only.
Yes, yes,
Okay.
yes.
So in our practice, when I see a patient, we routinely advise if the patient is not carrying the report, routinely a battery of tests, those relevant tests for all diabetic patients, those who are having diabetic retinopathy. So we need to control all those things, and at least in the first visit, we have to spend I mean, a minute extra to explain that this is not a disease. It is we are expressing in the eye. This is not an eye disease. Basically, part of systemic disease. So you have to have a good systemic control. See, there are number of patients who are having uh, intractable or rather non-responding to any kind of molecule. Again and again, you are giving injection especially the nephropathy patient, as soon as they undergo, they start dialyzing and that, or they've undergone the transplant, you will see the macular edema reduced drastically. So that is a very big evidence that is, the control is very, very important, especially the nephropathy, hypertension, and the dyslipidemia. This is very, very important. So I always tell there are two aspects of treating it. One aspect is you have to control the thing leading to your problem. And second, whatever happened in the eye, you have to inject or you have to do laser depending on the situation. But not only giving injection is going to cure you, or it is you will have uh, recurrence of macular edema again and again if you don't treat your basic conditions very strictly. That's what.
So we can invite others also if they discuss their routine practice and clinical experiences with us.
Yes. Abhishek,
Yeah, sir. Actually, I think many doctors they already attend, and you elaborately so discuss the every slide and every experience. I think no question from the audience side. If there is no question from
okay.
the audience, I think we can good to close because it's already they have heard for a long time, and many doctors already long.
Okay.
So I think already you have discussed the every point and every slide deck so like elaborately that everything. I don't think that any question from the audience end because there is no question on the chat box also. So thank you, Purnab sir,
Fine.
and to Avish
Okay.
sir
Thank you.
for your time. Thank you all audience for your time, sir. Hopefully, within short time, we'll again arrange this kind of meeting for the benefit of the society, for the benefit of the audience. So once again, thank you for your valuable time.
Thank you, everybody. Good night.
Good night.
Thank you everybody. Good night.
Good night.
So I'm requesting our technical team kindly log off this meeting session, meeting link.
Okay, sir. Thank you.
Okay, thank you.